Hello, everyone, and welcome to today's webinar, ACR Foundation 2018 Accomplishments and Updates for 2019. Before we get started, I would like to go over a few items so you know how to participate in today's event. When you join today's webinar, you selected to join either by phone call or computer audio. If for any reason you need to change your selection, you can do so by accessing your audio pane in your control panel. You will have the opportunity to submit text questions to today's presenter by typing your question into the questions pane of your control panel. You may send in your question at any time. We will collect these and address them during the Q&A session at the end of today's presentation. The presentation is available for download in the handout pane. You may download the handout at any time during the presentation. I would now like to introduce Dr. Danny Hughes, the Executive Director of Harvey L. Neiman Health Policy Institute.
Thank you and good afternoon. First, I would like to thank the generous contribution of the ACR Foundation to support this webinar and share the accomplishments we've had in health policy research over the past year. Again, to learn more about the foundation, please visit the acrfoundation.org website. Thank you. So today we're going to talk about health policy research, what we've accomplished over 2018, and various updates in terms of what we've done thus far in this year and the exciting new initiatives that we have over the remaining of the year. Just as a little bit of background, for those who are unfamiliar, the Harvey L. Neiman Health Policy Institute was established in 2012 by ACR's leadership to study the role and value of both radiology and radiologists and a number of important issues that are very important and vibrant and just critical to ensure we have evidence-based policy for the radiology community. These issues span everything from emerging care delivery models, understanding how you participate in alternative payment systems as the healthcare system transitions from volume to value-based payments, and also just understanding the impacts of utilization on overall healthcare cost and quality, as we try to ensure that patients receive the right image at the right time. Fundamentally, what we do is that we provide real data to inform real policy decisions. Over the span of our existence, we have well over 100 scientific publications and 100 presentations. I think for 2019, we're already looking at about 20 in the books. You can see we've started off in our first year at around 5 papers and have steadily grown over time to ensure that we're providing the evidence that policymakers need to ensure sustainable, reasonable change in this evolving healthcare environment. Of course, I'd like to add, even when I'm looking back next year and looking at 2019 and most likely finding something in 20s, who knows, maybe even 40 if this trend goes, we can't simply continue to grow forever. There's probably a plateau in terms of what's sustainable and how much research is really needed. But I think the key message from here is, particularly over the last year with our new mark of 25 publications, 25 presentations, that we're really doing a great job providing evidence in a wide variety of healthcare topics and ensuring the evidence is there when needed by policymakers, advocates, etc. So also in the past year, our research has been fairly high impact, I'd like to think. We've won a number of awards. The annual AMP Mini Awards had come out. Gave most influential radiology researcher to one of our affiliate senior research fellows, Andy Rosenkrantz at NYU. Other papers that have come out of our shop and collaborative efforts using our data and working with researchers at different academic centers across the country. Julie Cronin won the SAR Research Resident Award, and Patty Balthazar won a ACR Gold Medal at their annual meeting for different papers we put forth. And so again, the key, it's not just about volume of research, it's always about the quality and impact of that research. And I think by any metric, we've done a pretty good job with that. In fact, some would say by any metric, the HPI has really been wildly successful. We've got tremendous visibility, knowing that we're a very niche thing. Folks looking specifically for health policy research on imaging still manage to draw 30,000, 35,000 page views a year, 10,000 unique users, and another 13, 15, 17,000 sessions being raised. I think the key thing with users is interesting. If there's only, depending on who's doing the counting, 34 to 38,000 radiologists, that means we've got a third of all radiologists looking at our site. However, I look at the Google Analytics. I know that's not true. It's not, and I'm not indicating that radiologists aren't being as active. The point is a lot of our users are actual CMS, MedPAC, Health and Human Services, government agencies making policy. They come to our site to look at what's happened. If we look over the past 5 years, folks who've heard me talk before or maybe attended our last webinar, we have a number of very real health policy wins that our evidence has driven. Things like the Multiple Procedure Payment Reduction Act, that's now returning roughly $50 million a year in professional component reimbursements alone to the radiology community. Actually had CMS adopt our recommendation for what patient-facing should be or should not be for the radiology community. Some work addressing the veterans rule for expanding the scope of nurse practitioners in imaging. And I've spent a lot of time talking about things such as how we participated in the pre-authorization fight in Hawaii a few years ago. So the key thing that I'm sometimes asked is, well, where's the big win lately? Where is that? And you see, I don't have a bullet there. Now, this doesn't mean that when the proposed rule comes out that there aren't policy issues related to radiology. Just ask me one question about site-neutral payments or steerage, and you'll know there's a lot of issues that are very important facing this community. But we don't have maybe that signature win, and I'll give you a little story I'm stealing this anecdote from Bill Dorworth, by the way. So think about the Persian Gulf. Always a tumultuous place. Ships go through there. Is it going to be a Somali pirate? Is it going to be Iran with a gunboat? I don't know. But the bottom line is you solve that problem by putting a big, bright, shiny aircraft carrier in the middle of that sea. And then suddenly, you don't have major problems. You still have a small problem here or there, but mostly you've got a lot of bored sailors looking for something to do. Well, I think that's analogous to what we've done. Because if you take that aircraft carrier away, next thing you know, you've got a lot of problems there again. I like to think of it, now I'm not going to say that we're responsible for a dramatic reduction in very significant crosshairs and targets on the back of radiology. But I am going to say that we've been left alone for a couple of years. In my Google Analytics, I get a lot of views from government regulators. They're paying attention to what we do. So I'd like to think that we are the USS Neiman sitting in that sea protecting radiology shores. And so when someone's asking, what's the big win? Well, I'm going to talk about what we're working on, and I'll certainly provide an update on impactful research that's valuable. But I think the real accomplishment is by sitting here in these waters, we've done a pretty good job keeping the major targets and crosshairs off of radiology. Okay, moving forward, we asked ourselves a few years ago at ACR, what are the major strategic challenges we're going to face? Again, the Neiman Institute was founded in 2012. We had a number of big wins, and then it's cooled down, and we had to ask, where do we pivot next, besides just continuing to provide a very broad-based portfolio of evidence to inform policy? And quite frankly, there's a lot of strategic challenges. Things are getting much more complex, much more closer interactions between care delivery, payments, and quality, particularly as you move towards true quality and not process-based payment systems. Conventional research silos are generally inadequate for this because quality research generally occurs in a completely different facet, either in the academic world or even in the policy world, as opposed to people looking at healthcare policy or payments or reimbursements. And quite frankly, clinical trials today need to have these policy components to remain competitive and relevant in the post-large-scale clinical trial environment, where they're simply too expensive to have a very large clinical trial for everything that needs evidence. So these are very interesting challenges that really require a complex, holistic approach to policy. We also sat down and realized, well, the Neiman Institute has its own strategic challenges. This new world's really requiring more cutting-edge technology, broader ranges of data, broader ranges of skill. We need to make more advantage of machine learning, artificial intelligence, neural networks, other advanced methods, and we simply need greater flexibility to meet future needs. And you can see this as ACR has added commissions on patient-centered, having shared decision-making, understanding how new technologies are coming into play. The key question that we have to ask ourselves ultimately is, can we actually build a structure that's going to sustainably meet the needs, the future needs of this radiology community? Well, I'm going to argue that we can. And this year, that's an important accomplishment. So we spent the past couple years discussing with ACR leadership, reaching out to the academic community, and trying to understand how can we ensure that we remain relevant and can provide the needed evidence to continue to be again, objective and credible, and fulfill the roles we need in the policy community. And at that point, we developed a plan, which I'll talk about, and executed this year. So the original legacy structure was that the Nieman Institute was fundamentally organized as a department of the American College of Radiology. We have an independent advisory board, and we have separate branding, websites, and emails to have that firewall, but we're still fundamentally part of ACR. And so depending on how external stakeholders wish to scratch the surface, I mean, we don't hide how we're organized and where we're funded, but it's very important that we're seen as an objective, credible source of evidence and not simply a shill for the radiology community. So in consultations with ACR's leadership and a careful strategic planning and program assessment process, decided to move towards what we call the multi-core Nieman Institute concept. I like to think of this as the franchise model. And so basically you've got an ACR-based administrative core, handles our support, our web assets, external grants for the grants that we hand out, communications, marketing, and has support analysts who manage the data that must be housed at ACR, and to perform queries as we integrate closely with economics and the RUC team and other teams that really need this cutting-edge research to support ACR operations. But then we have what Jim Brink coined as a semi-permeable membrane that separates, a real firewall between university-based centers, where we partner and develop centers at individual universities where we have unquestioned objectivity and credibility, comes with the university brand. And there we house the really forward edge science on the academic side, where we have our health policy, our economists, our clinical researchers, our data scientists. We perform educational activities and still have resources for ACR members, just like the administrative core. But again, there will be comparative advantages based on the franchises. So I'm pleased to announce that one of our key accomplishments was revamping the structure, streamlining the core administrative components in our Reston-based headquarters, and then developing a series of franchises, if you will, on the academic side. So in February 2018, we brought online an Outcomes Research Center in conjunction with Northwell Health and Hofstra University up on Long Island. This was designed to really examine how clinical effectiveness and cost effectiveness, really just outcomes, can be incorporated into policy in a meaningful way as policymakers are trying to tie real outcomes towards payments. And they've been very successful. They're working on a number of projects. Again, they started February 2018. It takes time to get into publication, but they've been working on stroke pathways, understanding pulmonary embolism, and trying to understand how quality and policies can change that. We also have in August 2018, we put online the Health Economics and Analytics Lab at Georgia Tech. I'll give you a whole slide on that, focused on big data analytics. We just started literally 1 month into the Imaging Policy Analytics for Clinical Transformation at Emory, which is fundamentally distinguished by the fact that they have unique data there, the MarketScan database that they can leverage and exploit. And then also we're participating in educational activities through the AARP, which is really a workshop for PGY 3s and 4s to expose them to a broader range of activities within radiology. And this particular workshop is designed to understand clinical and cost effectiveness research and have synergies with what we're doing with our Northwell Center. So the Health Economics Analytics Lab, I'll spend a little more time on, because this is quite a departure from what we've done in the past. I think folks on this call understand fundamentally performing policy research with large data and understand outcomes research. But this center is designed to actually look at advanced analytics, artificial intelligence, machine learning on large-scale data. And what we actually have there is a very large commercial medical claims database that only 6 other academic centers have, that has more than 19 million Americans covered and literally billions of lines of claims. Fun part is that it's housed in the CODA building that was just opened a few months ago. It is the largest dedicated data analytics building on an academic campus. Also features the world's largest spiral staircase, so I haven't tried to go all the way to the top. I got about halfway. But the key is the floors are organized by theme. And we're on a healthcare floor where it has researchers spanning computer science, industrial engineering, operations research, and public policy to make sure we have the flexible set of skills we need, all united around informing the national medical imaging policy debate and doing that in an effective way with very unique data we couldn't work with otherwise. Fun parts in terms of that center is that they're also contributing roughly $250,000 a year in both monetary and in-kind matching to the ACR grant. And so that's something, as we think about this franchise model, we look for partners. Are there unique niches? Can we find other franchises, other models where we've got a collaborative environment, sharing data, sharing resources towards a common aim where we can find joint, mutually successful wins? Okay, moving on, I would like to talk some about our research highlights. As I mentioned, at this exact moment, we've got somewhere, I think, 35 papers in 2018 and another almost 20 in the books for 2019. So it would be impractical for me to go through and discuss 50-odd papers. But I would like to pick just a few out where I can give you a little more depth over what exactly we've done and how we're really providing evidence in a meaningful way for the radiology community. First one I'd like to talk about is a paper that's still published online. It's not in print yet, but it's already out there and can change policy in a meaningful way. This is some current problems in diagnostic radiology. And it's a paper where we examined the complexity of patients that went to emergency departments and received head CTs. And this is important because when you're thinking about the RUC or the RVU process, how are you putting valuations associated with images? You perform surveys and people provide, time and motion studies and try to provide, how many minutes and how many resources and what's the practice expense and how does that work? But it's a very average process that's averaged specifically for head CT. But after digging to the data, anecdotally we recognize, head CT is mostly occurring in emergency departments. And I suspect if you're in an emergency department, those patients are maybe a hair more complex. Maybe those reads take a little more time. Maybe those RVUs are not quite what they should be. And so we collected a lot of Medicare data within our center and realized that, yes, indeed, head CT is overwhelmingly, most frequently ordered in the emergency department. And it turns out that overwhelmingly, let me not paraphrase out and get fact-checked if I'm off by 1 percentage point, but somewhere in the top, quartile of all these patients, 75, 80% or so, are all E&M codes with complexities 4 or 5, the most complex patients you could possibly find. And so it seems pretty clear that if you're basing your RVUs on just the average weighting of all patients and all places of services based on these surveys, it's probably not capturing the real complexity and the real amount of effort required to perform these reads. And so ideally, this is going to be important ammunition for ACR's economics team when you go forth and try to think about how you want to value these codes in the future. Next component, we've spent quite a bit of time in efforts at the Nieman Institute over the past 4 or 5 years thinking about bundled payments. Alternative payment models really don't have a lot to offer radiologists at the moment, and that's very challenging. It's hard to figure out how can you participate directly in these models in a meaningful way, and we've spent quite a bit of time putting out evidence. I know the economics team has spent quite a bit of efforts reaching out to CMS, trying to have screening models that would cover maybe a bundle from the initial screen all the way to the point of diagnosis and cover all downstream imaging. We published a paper a couple years ago really demonstrating what that sort of model would look like. But now 2 years later, it turns out digital breast tomosynthesis is everywhere. We've got new technologies. We've got to update this model to see if it works. And that's where things are interesting because technically there's an additional fee for that. So obviously you would expect the bundled payment itself to increase. But the theory behind DBT is that it actually gives us a benefit. We're not just doing it for higher reimbursements. We're not insisting we have this new technology. And so working with colleagues at Emory University through their center and using their institution's data, we discovered that, yes, the cost, in fact, does go up in the bundled payment, but it turns out it significantly reduces recall rates from 13% to about 9.4, at least in that example. So that's a lot of downstream imaging that's no longer occurring. And so it seems like it could be a very valuable way, again, to preserve patients, ensuring they're having the right amount of utilization, but could still participate, be an important component within a bundled payment without making that bundled payment become too unwieldy. Another paper I'd like to highlight, we had a paper in Preventive Care, the latter half of 2018. This is one where people scratch their head and say, I sort of see the paper, but what's this got to do with us in radiology? Well, let me explain. So back in 2011, Medicare authorized an annual wellness visit once a year for Medicare beneficiaries. This annual wellness visit is not a physical. It's literally a visit to sit down and coordinate care Ask patients about their preventive care utilization specifically and understand how they're doing that. And if are they taking the right drugs? Are they getting the right preventive services? Now, you might think, aren't they already doing this? Well, it turns out if you don't specifically pay a primary care physician to do it, your mileage may be mixed in terms of how often this occurs in their regular office visits, where patients are usually setting up for acute care anyway, and they're focused on the immediate symptoms. So we asked ourselves, does this actually effectively change preventive care utilization? And the answer is, if you look at key results, these are the odds ratios, yes, it does. For patients who attended an annual wellness visit, mammography, you were 63% more likely to get a mammogram than if you did not. Twofold, really 250% more likely to have a colon cancer screening. 2% bone mass measurements, another 1.8 for cancer screening for prostate. That's fairly significant numbers. So it was pretty overwhelming, and this was a very robust study, that the annual wellness visit makes a difference on utilization of preventive services. Why do we care? Well, I have heard and have read that under the current administration's plans, as they look for ways to save and cut costs in the Medicare program, that the annual wellness visit may not be something that we really need to have. But it turns out that it's very effective at having people receive the preventive services and have the population health that they need. And most importantly, if you're thinking as a radiologist potentially, you remove an annual wellness visit, how many of these procedures go away as people revert back to, I don't know, should I do the mammogram or not? Just depends. And finally, I'd like to talk about radiology and accountable care. We had a paper done, this is an engineering journal, Healthcare Management Science. So again, you want to influence policy, you often want to publish outside of radiology. So policymakers and other influencers are reading this document. Here we explicitly modeled under what conditions would different providers, specifically radiologists or primary cares, want to join an ACO. And without going through all of the details, let me just say what the simulation model produced. It indicates that a radiologist is likely only to be asked to join an ACO if the savings threshold is already very tight. If there seems to be enough fat and the primary care physician or hospital thinks they can find savings, they won't even bother to ask you. And that's interesting because that comports very well with the anecdotal evidence I've heard from radiologists in practices in ACOs who say we've never seen a bonus payment. Well, that's because they only invited you to join because they didn't think they could beat the bonus payment. Now, this is a theoretical model, but part of our work going forward is actually to test this with real data. And we should have that until my next slide when I talk about what we're doing. That's something we're looking at right now with Medicare data because I've received the 100% list of every provider and patient in every Medicare ACO in the country. And we're going to see what happens and look at the composition of those ACOs and what happens when radiology is in them and not in them. Does this comport with large-scale empirical data as well as with the anecdotes? So let me move forward with what we're doing in 2019. Again, at any given point in time, we're probably working on 25 to 35 projects at different points of the review period, different investigators, different data collection stages. But I've got four I would like to highlight. One is that we're working in conjunction with the American Cancer Society under a request from the ACR Commission of Patient and Family-Centered Care to help develop an online tool or some kind of tool to actually identify gaps in lung cancer screening nationwide and to promote the use of lung cancer screening. This tool is either going to indicate at the zip code or county level, we're still working on that, what is the smoking incidence? What is the lung cancer incidence? How many currently accredited screening programs are even in that area? This is going to allow radiology practices to find opportunities to meet this critical need. Another important initiative is continuing to look at this breast bundled screening effort. What is the evidence it's going to take to finally get an APM so radiologists can participate in this value-based world? Right now, we're requested by ACR's Board of Chancellors to examine how does patient cost sharing perhaps change downstream utilization after a positive mammogram? Because it turns out, mammograms are generally covered. You can usually find some way to have a free mammogram. But when you come back for that diagnostic, that ultrasound, or maybe an MRI, then things change. And we had a paper a couple years ago in radiology indicating that women who had false positives were much less likely to go forth and continue if they have another positive mammography screen. Preliminary results on this indicate that yes, indeed, patients are in fact sensitive to cost sharing, and that may be changing their decisions to seek downstream services after a positive mammogram. Now, we can't account for all the reasons why, but if it turns out to be really tied to finances, that's more evidence that a breast screening bundle, where all the costs are front-loaded for the patient, might be the way to go in terms, and also providing additional evidence that radiologists can add true value in value-based payments. Finally, we had a request from the ACR Commission on General Small Emergency and Rural Practices to examine variation and disparities in access to advanced imaging. Why rural hospitals are closing at an alarming rate. There are strong concerns about the access and availability of advanced imaging in those populations. And again, we have preliminary results we're writing up now that indicates very strongly, significantly, and meaningfully in terms of the nominal changes. That yes, indeed, rural hospitals offer far fewer advanced imaging to find a CT and MRI. And so that's an important issue. And then finally, as I already mentioned, we're taking empirical data to further understand where do radiologists and radiology practices fit in accountable care organizations. We have a simulation model. We've done some theoretical work. We've got a lot of anecdotes. Let's see what the data says. So at this point, again, I think we've had a great year in 2018. We've got some very exciting deliverables that are going to add very impactful evidence that will change important areas of relevance to the radiology community. But I would like to turn it over for questions. Thank you.
Thank you, Dr. Hughes. We're now going to begin answering questions submitted during today's presentation. As a reminder, you can still submit your questions through the questions pane of your control panel. Our first question is, what exactly are you doing with artificial intelligence / machine learning at the Hill Lab?
That's a great question. So again, we just started the Hill Lab last year. We're 1 year in. And so a lot of what we've been doing is really building infrastructure, ensuring we have the data set up, building analytical files. But we do have a couple teaser projects that we are examining. For example, I was made aware that the Center for Research and Innovation at ACR's Philly location received a significant grant from the Alzheimer's Foundation to examine Alzheimer's imaging. Can they develop imaging tests that are more likely to identify who has Alzheimer's and who doesn't? And that leads to interesting questions. For example, we know we've got a test for mammography, for breast cancer. It's called mammography. And we also understand that now that we have this test, who should have those mammograms? Now, I say we understand. I recognize there are competing guidelines and et cetera, but I'll just follow on the American Cancer Society's guidelines that indicate that all women over 40 should have an annual mammogram. Well, suppose we have this test for Alzheimer's. Suppose we find this imaging test. And I know there's people working on blood tests, et cetera, but when we have it, who gets that test? That's not so obvious. And so we're using machine learning. We've got a team of researchers that have already performed some preliminary work, taking Medicare claims from patients who were diagnosed with Alzheimer's with a matched cohort of patients who were not diagnosed, and we followed them into the future to make sure they also weren't diagnosed several years in the future, and we're not just grabbing false cases. And we took their medical utilization claims from 3 to 7 years prior to this diagnosis. And using that with a number of machine learning, support vector machines, and neural networks, we examined that right now our misclassification rate is about 30%. So we're hoping to improve that. But what it demonstrates is, can we develop a heuristic that uses just utilization, diagnosis codes, procedure codes, timing between these events? Can we actually take that and embed it into a heuristic that could go into a payer or healthcare system or hospital to indicate patients that potentially should be screened for this test? And so that's an example of how we're actually using that, at least our first big win. Again, we're still preliminary result in that area, but it's certainly an area that we're trying to leverage data to use.
All right, thank you. I think we have time for one more question. What would you do with additional funding for the HPI?
What would I do with additional funding? Well, so there's two different things we have to think about when we look at additional funding. One, you have to look at the volume of deliverables that we've been putting forth and how they've been growing. And we have to ask ourselves, what is the right size and scale? But ultimately, it's really not about the number of papers. I don't think additional dollars generates more papers. I think additional dollars generates higher quality research. What sort of additional partnerships can you develop? Can you expand the data processing at the Heal Lab as we move further into artificial intelligence to leverage data? Are there other potential data sets out there? And the answer is yes, there are many that we could leverage more fully, because right now we largely use Medicare data at our Reston Center. We're using a very large commercial claims data set at the Georgia Tech Center. We've got market scan data at Emory, but all of those aren't fully generalizable as much as you would like. So certainly finding partnerships to require richer, most diverse sets of data, and simply just trying to make sure we still have access to the kinds of analytical skills and support we need. I'd like to say we have enough engineers and enough data scientists, but it turns out it's very difficult in both the academic and the not-for-profit space to keep a hold of those folks. And also at the same time, if I go back a slide, and I will, you can see that ACR commissions, ACR leadership has directly requested a number of these studies. But we also have to maintain a very intentionally diverse, broad set of studies for problems down the road we can't anticipate. And I've given a number of talks about those. So issues like tort reform, malpractice, understanding changing guidelines and how that's going to influence utilization, understanding more payment models. There's always a shortage of having the right partners and resources to ensure that we can explore those, because when we look at our research portfolio, it usually starts with in terms of what are the important issues for things folks have directly asked us to work with, and what are the more speculative things that we really need evidence for. And of course, we reweight based upon urgency, but that often can lead to a short shrift on the things that really need to be done for the future. And that's really the key in terms of how I think about dollars. If I had more dollars, I'd probably immediately bring in a couple more data scientists and maybe look for expanding one of these partnerships or looking for another great partner in a franchise model.
All right. Well, thank you, Dr. Hughes, and thank you, everyone, for attending today's webinar. If you have any other questions, please contact Brandy William, the ACR Foundation's fundraising specialist, at bwilliam@acr.org. On behalf of the ACR Foundation and our presenter, thank you for joining us today, and have a great rest of your day.